Okay, first of all, I'd like to mention most of you already know me. I have had my training here. I have basically lived in Mr. Hospital, Multan for nearly 27 years, but for the last 1.5 years we had to move out, and now for the last few months I am working in Bahawalpur. To come back and talk here in front of my dear respected teachers, it's an honor and it's like a dream come true. So now we'll go into the details. As the surgery has been done, we'll see how to read an X-ray after the surgery. I would request my participants as well as the residents to kindly interact. This should be sort of an interactive session. We have gone through almost all the theoretical details, so it should be interactive. So I would request residents on RS and everybody to kindly interact. Okay, so total knee replacement. This X-ray was taken in the recovery room. This came back. Everything fine here? Please speak up loudly.
It looks like a fracture on the medial condyle of the femur.
Yes, there is a minimally displaced fracture of the medial condyle. So one has to one should know how to read the X-rays. An average orthopedic surgeon should also have the basic concepts of reading out the X-rays taken after total knee replacement. So I would like to quote this quotation of Professor Haider. He is my teacher. He used to tell me that my best teacher is my post-operative X-ray. And this is in fact very true because even if a surgery has been done very nicely, one can look into the minor details and sort of try to find out the ways in improving those minor tiny details which can ultimately make a difference in the long run. Okay, so why is it important to be able to read the X-rays? Knee and hips, they are the most commonly joints being replaced today, and the literature says that by 2030 the number of joints being replaced would be 5 times higher compared to what are being replaced today. So it is imperative for the surgeons to be able to read the post-operative X-rays. More and more surgeons are now basically taking interest in this specialty. Since this surgery is being done more commonly now, such patients would turn up to many orthopedic surgeons for their follow-up. So they should have the basic concepts of arthroplasty and be able to read the X-rays so that one can look for early and late complications including fracture, loosening, infection, instability, osteolysis, ossification, complications related with extensor mechanism and the patellofemoral malalignment, etc. So, in post-operative period, what X-rays should we be having? At least 3 primary X-rays which include an AP standing view, preferably a lateral view, is skyline view. One can get a scanograph if the facility is available. Okay, so in the X-ray, one should look for the type of prosthesis. This is important for a person who basically has not done the surgery himself. He should be able to find out the type of implant that's been done. One can look at the components, their positioning, the overall alignment, and any iatrogenic injury like a fracture or ligament injury. So, which type of prosthesis is it? Participants. This is a primary knee, but which type? Is it cruciate retaining or is it posterior stabilized? Yes, this one is cruciate retaining. How do we find out? What do we need to look for in the X-rays to be able to say that this is a cruciate retaining type of prosthesis? Well, if you look carefully at the femoral component on an AP view, there is no notch. Right? If it is a posterior stabilized implant, there has to be a notch, and along with the CAM mechanism, and likewise the pony would have a bigger post. If you look at the lateral view, again there is no notch on the femoral component. So this is a cruciate retaining type of prosthesis. And likewise mentioned here, this one is a posterior stabilized. The notch is visible both in anteroposterior and the lateral. This one is a constrained prosthesis. Just to show the unicompartmental arthroplasty. The figure on the right shows the medial compartment being replaced, and one on the left basically is showing the patellofemoral compartment being replaced lower. Okay, so in a normal AP radiograph taken after the surgery, what are we looking for? We should be looking at the mechanical axis. We have gone through the theoretical details, the mechanical axis should be restored. The mechanical axis in fact is a line connecting the head of the femur to the ankle, the center of the ankle. It should normally pass exactly through the center of the knee. The mechanical axis should be restored. For the restoration of mechanical axis, the femoral component should be in 5 to 7 degrees of external rotation. The tibial component should be perpendicular to the anatomical axis of tibia. One can also look for the joint space. The joint space medially as well as laterally it should be uniformly distributed. If one is unable to appreciate the joint space, this can be due to a flexion deformity still persisting after the surgery. Okay, one can look for the components being either too far medialized or too far lateralized on tibia as well as femur. On an AP view, one can look for the patellar shadow and its position in the supra-inferior as well as the mediolateral direction. One should appreciate all bony surfaces along the femur and tibia to look for any iatrogenic fracture or any breach in the continuity of the cortices. The ossification is a late presentation. So this is a normal AP view showing the femoral and tibial component along with the joint space clearly. The scanogram, as already mentioned, this would be best in predicting the mechanical axis and if there is any lateral discrepancy. Okay, on a lateral radiograph of the knee, the femoral component. On a lateral view, we can assess the sizing of the femoral component. The anterior plane as well as the posterior condyles, they should be firmly in contact with the femur. If there is an overhang posteriorly or if there is lodging anteriorly, it should be looked for carefully. And if we draw a horizontal line along the distal femoral cut along the femoral component, it should be at 90 degrees to the long axis of the femur. Few surgeons tend to flex it by 3 to 5 degrees, so it is according to the surgeon's preference. Likewise, the tibial component, its size should be assessed, and again it should be perpendicular to the long axis of tibia, or it can be up to 5 degrees inclined posteriorly. The patella, it is best visualized from the lateral view and the skyline view. On the lateral view, one has to visualize the anterior surface of patella, the articulation of the patella with the newer coating that has been put in. One should appreciate for the thickness of the patella along its cut from superior to inferior, and as well as the position of the patella. I mean, is there patella alta, patella baja, which may be due to fracture of the ligament, either the ligamentum patelli or the rupture of the extensor mechanism. Likewise, the suprapatellar or the posterior regions can be looked for any loose body or any extra cement that might have been left behind. So this is the lateral view. The lateral view also is helpful in determining the rotation of the components. In a pure lateral view, if one of the components appears to be tilted, it gives us a rough idea about malrotation. The exact idea of rotation basically is with CT. And then the skyline view. The skyline view is best for assessing the patellofemoral alignment and the mediolateral thickness of the patella that has been left. Ideally, the patella and the component should be centered over the middle of the trochlea of the femoral component in this skyline view. And as has already been mentioned, the patellar malalignment is one of the commonest complications that is encountered, and in fact one of the commonest reasons for the revision of the knee. This is the skyline view and the lateral view showing the alignment of the patella. Okay, so these X-rays are showing instability. If we look on to the X-ray to the right, the valgus stress has been given to the knee and it shows gross opening up medially. So this clearly gives an indication of an insufficiency of the medial to lateral ligament. Something needs to be done. On the lateral view shown here, this shows anteroposterior instability, basically a dislocation. In these particular views, again, like the view mentioned, the one which was shown earlier, there is fracture of the medial epicondyle. If one such fracture is appreciated peroperatively, something needs to be done. If it is appreciated post-operatively, then again it needs to be assessed. If it is stable enough, a few surgeons may want to proceed conservatively, keeping it close follow-up with the patient, or some would want to put in percutaneous screws to fix it.